Okay, well, welcome and thank you all of you for joining today's webinar. I first and foremost, I want to apologize. I am getting out of a little bit of a cold, so I'm going to be with some drinking things and trying to keep my voice alive until the end of this webinar. And I hope we're going to get through it well. Yeah, so today we're going to talk about OCD and its related disorders, um, which is a very interesting topic that can be somewhat theoretical at times. So I try to make it as practical as possible. I'm going to explain to you how. My name is Dr. Sophia Wenzler. I'm a licensed clinical psychologist and also the clinical lead here at Stop OCD. Um, Stop OCD is basically bringing this webinar to you. It's a therapist-assisted online program that can help you cope with intrusive thoughts and compulsive behaviors. And I want to encourage you to stick around until the end of this webinar. I'm going to talk for about 40 minutes. First of all, because we're going to have a Q&A session where you can ask questions that came up during the webinar or questions you have in general that are related to OCD. You can write those down in the Q&A section here in Zoom. Please don't raise your hand. I'm not going to react to raised hands. You can write the question down. If I get it wrong, you can even write another question or clarify or whatever you want. I usually get to all of those until the end of the webinar. And also, we're going to have a promo code for you. So in case you want to sign up for Stop OCD, you are going to get a promo code for a $100 discount at the end of this webinar. Okay, so what we're going to do today is, first of all, I want to explain to you what is this category. It's actually a clinical category of conditions, obsessive compulsive and related disorders. And then we're going to get to know all of those other disorders that are grouped together with OCD. I'm going to try to make that a little bit more interesting by doing it with case examples. We're going to talk about what they all have in common, but also where they're different and where misdiagnoses can come up. And then we're going to look at the treatment options and jump into the Q&A at the end. Just checking that there's no questions yet. That's always a sign for me that all of you can hear me well. Great. Okay, so what's interesting about obsessive compulsive and related disorders? This is basically a new group, a new category in what we know from statistic manuals. So basically, when we're talking about ways to categorize clinical disorders, then we use either the DSM, the Diagnostic and Statistical Manual of Mental Health, which is mostly used in the US, and it's brought forth by the American Psychology Association, the APA. Or we are talking about the ICD, which is the International Classification of Diseases, which is brought forth, just comes from the World Health Organization, okay? And so basically in both of those manuals, the DSM and the ICD, there's a change that happened quite recently in how we categorize OCD. So in both of those manuals, OCD used to be classified as an anxiety disorder, as you see here with the DSM-4, and that came out in 1994. Obsessive compulsive disorder was organized together with other anxiety disorders such as panic disorder or PTSD or specific phobias. And then it kind of became its own group, like a group that is basically centered around OCD. It's literally called obsessive compulsive and related disorders. So this happened in both manuals, and it's just an interesting uh, development that shows that our perspective on OCD changed, at least in this kind of theoretical perspective. And the rationale for grouping OCD differently and not with anxiety disorders is that the idea for this new group is based on common clinical features of repetitive unwanted thoughts and associated behaviors, compulsive behaviors, um, as well as emerging evidence from imaging, neurochemical, and genetic studies. So the idea is that all of those disorders that we're going to look at in this group have a pattern of repetitive unwanted thoughts and associated, usually compulsive behaviors. So if you look at OCD, as I like to do, in ways of a cycle, then there is a shift in this categorizing OCD as an anxiety disorder previously to now giving its basically its own category. Okay, I'm just going to repeat the cycle of OCD quickly because it also just gives us a quick repetition of what OCD is. Okay, so OCD usually involves a trigger. Let's say leaving the house can be a trigger for people with checking OCD. They might have an intrusive thought. For example, what if I left the stove on? They will interpret that thought in a certain way, overestimating the likelihood of the stove being on and overestimating also the catastrophic events that might occur that causes distress. And then we do something to reduce the distress, either avoid being the last one, for example, who leaves the house, or avoiding using the stove, or compulsive behavior where we go back again and again and check. And so if we look at the aspect of OCD that OCD has in common with anxiety disorders, then I would say that's the part that I circled here, the catastrophic interpretation of certain thoughts. For example, in social anxiety, I would have an exaggerated interpretation of how horrible it would be to do something stupid or embarrassing in front of other people. Or when I have a phobia of dogs, I exaggerate my idea of how dangerous dogs are. So it's like the interpretation of my thoughts, as well as the distress, right? The anxiety. That's literally like in the name, anxiety disorders. And we also feel anxiety when we have OCD. So that for me is kind of the old way of looking at it. And the new way of looking at it is more in terms of, okay, there's repetitive, unwanted thoughts that are uncomfortable that lead to compulsive behavior. Um, and this is the focus, the new focus around which all of those disorders were grouped together with OCD. That's my interpretation. So when now I'm going to talk to you about all of those other disorders that we find in this category, I want you to remember what we're looking for is intrusive thoughts, which I would define as unintended or unwanted, recurring and causing distress, and compulsive behaviors. And compulsive behaviors I would define as something that leads to relief in the short term, is hard to control and repetitive, and leads to negative consequences in the long run. Um, and as I mentioned before, you can find this category of obsessive compulsive and related disorders in the DSM-5, which is the newest version of the DSM, as well as in the ICD-11, which came out in 2022. In both manuals, you have OCD in this group, body dysmorphic disorder, hoarding disorder, as well as a group of disorders that are called body-focused repetitive behaviors. Those can be, for example, pulling out your hair, picking at your skin, biting your cheeks, biting your nails, things like that. And then we have some kind of like category of things that are hard to define, but maybe in the realms of this somewhere, which is called other specified OCRDs or unspecified OCRDs. And then in the ICD 11, we specifically have two more disorders, olfactory reference disorder, and hypochondriasis, which I hope until the end of the webinar I'm going to say this word smoothly. And those are the disorders that I want to, those six: OCD, body dysmorphic disorder, hoarding disorder, BFRBs, olfactory reference disorder, and hypochondriasis are the ones that I want to give you some more information about. I think six is enough for one webinar. Um, so I'm going to give you some case examples, and you can basically, guess along while I'm reading and think about which one of the six disorders that I mentioned previously this might be. And then I'm going to explain why. The first one: Benjamin believes his hands are disproportionately small, even though others reassure him they look normal. He spends hours in front of the mirror each day examining himself and panicking about the implications of those small hands. His preoccupation makes him skip social events and dates, fearing others will notice his defect. He tends to compare his hands with those of random people on the streets. So that would be an example for body dysmorphic disorder. Body dysmorphic disorder basically means a preoccupation with perceived flaws or defects in appearance that are usually non-existent or exaggerated if you would ask someone else. And for people with body dysmorphic disorder, triggers can be mirrors, pictures, photos, social comparisons, intimate social situations, many different things. And the thoughts, because we're looking for, intrusive, unwanted thoughts, the thoughts that trigger the behavior can be something like: my nose looks deformed, everyone's staring at me, I look disgusting, abnormal, ugly. If I don't hide this, people will reject me. And those thoughts then lead to compulsive behavior such as excessive grooming, mirror checking, seeking reassurance about appearance, and things like that. So basically, if we're looking for those two main identifiers of this group, we see a lot of unintended negative thoughts, and we also clearly see compulsive behavior. The next one: Linda keeps every box, receipt, and plastic bag just in case. Over the years, her living room filled with piles so high that visitors can no longer sit or even walk easily. Her boyfriend broke up with her because he couldn't stand it anymore. She insists she might still need this even when talking about broken appliances or expired food. Although she feels embarrassed, the thought of throwing anything away causes overwhelming anxiety. What could that be? So this would be an example of hoarding disorder. So that means the excessive acquisition of and failure to discard possessions regardless of their actual value. Triggers can be any situation, thought, or emotion that sparks the urge to acquire, save, or avoid discarding items. Here, the thoughts are, well, we're going to discuss later if we really want to define those as unwanted or intrusive thoughts, but thoughts that can trigger the behavior might be based on emotional significance. This reminds me of my 6th birthday. Instrumental significance, I might still use this, or aesthetic significant. It is too beautiful to throw away. And the behaviors, as in the definition of the disorder, is the acquisition of the items and the failure to discard possessions, even if the whole house is cluttered. Next example. Whenever Tilda notices a tiny bump on her skin, she feels the strong urge to pick at it, sometimes until the skin is broken and bleeding. This can happen in stressful situations, but also when she's just chilling with her phone at home. She tells herself she'll stop after fixing just this one spot, but the picking often goes on after that. She feels deeply self conscious and avoids wearing short sleeves or swimsuits in public. So, that would be one example of one of those body focused repetitive behaviors, in short, BFRBs. In this case, we're talking about skin picking, might as well be hair pulling or nail biting. So when you have a BFRB, you basically experience recurrent urges to pull out your hair or pick at your skin that are really hard to resist and create a lot of damage and distress. And here, the triggers can be basically anything from boredom to stress to, sorry, negative thoughts or emotions, or even just certain times of day or certain places. Um, and basically, thoughts can be triggering. If you have a negative thought that causes a negative emotion, the picking or pulling can help you regulate this emotion, but it doesn't have to be related to a thought. Sometimes BFRBs can also be based on habit or even reward driven because the feeling of plucking out a hair or picking your skin can also be rewarding, almost like this feeling when you pluck out a gray hair or when you how do you call it, squish a pimple or you know what I mean, like uh, you you do the thing with the pimple that we have all done before. Um, and also in terms of we're looking for compulsive behavior. So with BFRBs, it's a little bit, it can be both. It can be compulsive. You can be like, okay, I have to pull my hair right now. I have to pick my skin. Just like when you feel like I have to check the stove. But it can also be impulsive in terms of like, oh, wow, I wasn't even noticing my hand wander to my head and I just put five hairs out and I didn't even notice that this was happening, right? So the behaviors are not always perceived as compulsive by by the person who suffer from the FRBs. Then we have another case example. Dean frequently fixates on minor bodily sensations like aches in his fingers or chest pains, interpreting them as signs of serious illness. He obsesses over possible diseases, including cancer. When symptoms appear, he seeks medical evaluation, often going to multiple doctors and specialists for reassurance. The cycle of worry, checking, and temporary relief repeats, sometimes lasting days, weeks, or months. Oopsie. All right, let's go back. So that would be an example for hypochondriasis, the persistent preoccupation or fear about the possibility of having one or more serious, progressive, or life-threatening illnesses. So here, triggers can be anything from bodily signs and symptoms that we kind of pay excessive attention to external cues. For example, hearing about illness from others or in the media. And the thoughts are usually what if questions. What if my headache means that I have cancer? What if my doctor overlooked something when he checked me? And the behaviors are clearly compulsive in terms of excessive checking of body, searching for information, or seeking medical reassurance. Or it can be avoidance of the topic, not even wanting to be exposed to any information that is related to health or illness. And I think this is the last case example. Mika is convinced he gives off a foul body odor, even though no one else smells anything unusual. When a colleague opens a window in the office, he interprets it as proof he stinks. He showers multiple times a day and uses strong deodorants, but never feels clean enough. The fear makes him avoid public transportation, close conversations, and social gatherings. Oftentimes, he has trouble concentrating when at work or with others because he's so preoccupied. So that would be an example for olfactory reference disorder, which I have to admit I don't have clinical experience with. This is a disorder that was only included, not included in the DSM, and was only included in the ICD-11, which came out in 2022. So it's very new. We don't have a lot of uh, information about it. For example, I was asking myself, how common is this? And so prevalence rates are still unclear. Maybe they lie between 0.5% to 2%, but estimations at this point are likely wrong because a lot of clinicians don't know of this disorder. So I thought this was very interesting. It clearly has, the two aspects that we're looking for, the thoughts and the compulsive behaviors. It can be triggered by a lot of different things like bodily sensations. For example, when you feel like you're sweating or you feel like you're bloated. External cues such as being in a bus or eating garlic, as well as internal triggers. So memories, thoughts, emotions, everything that comes up. And then thoughts come up such as like, what if I'm smelly? What if I'm giving off a foul odor? Everyone can probably smell my sweat, or maybe I just should brush my teeth again just in case. Maybe there is some garlic smell left or whatever. And then the behaviors are clearly compulsive, excessively checking for body odor, camouflaging perceived odor with perfume or deodorant, excessively bathing, brushing your teeth, changing clothes, and avoiding social situations. So now I hope in a less boring way, you have some idea of what of what all of those disorders mean. Um, and let's see if they all are similar to OCD in terms of intrusive thoughts and compulsive behaviors based on what we just learned. So I would say body dysmorphic disorder is very, very close to OCD in its symptomology. You have recurrent unwanted thoughts that cause distress for sure, and you have highly compulsive behaviors. I did put the V in brackets here because I do want to um, make one distinction about intrusive thoughts with OCD that kind of sets intrusive thoughts with OCD apart from all of the other disorders, which is that intrusive thoughts in OCD a lot of the time are perceived as ego dystonic. Ego dystonic means basically not belonging to me. Now, it's not like when you're psychotic and you feel like you have a voice talking to yourself, but a lot of people suffering from OCD clearly wonder, it's like, why am I having those thoughts? Why would I have thoughts of hurting another person? Why do I have forbidden sexual or religious thoughts? Why can't I stop thinking about turning the stove off? Right? What does this have to do with me? So it feels like almost like not belonging to yourself. It feels like it's not in line with your values. That's what ego dystonic means. And in the newer definition of OCD, it's not it. The intrusive thoughts don't have to be ego dystonic, um, but a lot of the times they are. A lot of the times, people that I see with OCD ask me like, why me? Why those thoughts, right? And that's that effect. You don't have that in with the other disorders that much. So that's why I put the intrusive thoughts, these all in brackets, because I feel like there is a certain quality to intrusive thoughts when it's really OCD. When you look at hypochondriasis, you also have recurring thoughts about an illness that are unwanted that cause distress, and you have compulsive behaviors in terms of the checking and reassurance seeking. And the same goes for this mysterious olfactory reference disorder. So basically, body dysmorphic disorder, hypochondriasis, and olfactory reference disorder are very, very similar to OCD. When we're looking at hoarding disorder, it's a little bit different because hoarding behavior doesn't necessarily have to be caused by uncomfortable, unwanted thoughts. Like the thoughts seem much more in line with oneself, much more logical to the person, right? I might still use this. Oh no, I love this. It reminds me of what happened this and that day. So I wouldn't say it's necessarily that people with hoarding disorder necessarily have to have intrusive thoughts. And it's also like hard to call it compulsive behavior when it's just like, I don't want to throw it away. Maybe sometimes compulsively buying things, um, but it's not the compulsive behavior in terms of like I have to do something to feel better now. Like I have to check my hands to be less worried about their size, or I have to check the stove so I know it's off. It's a different kind of um, behavior that's not always compulsive. And then I would say basically BFRBs, body focused repetitive behaviors, are definitely the furthest away from OCD in their character. So intrusive thoughts are barely, definitely not the main trigger for BFRBs. And the behavior can be compulsive, but as I mentioned before, it can also be impulsive. So I do see a lot of differences between OCD and body focused repetitive behaviors, which is interesting because BFRBs are actually often misdiagnosed for OCD, but I'm going to talk about that um, more in depth later. Um, so let's look at some other common features of the different diagnoses in this group. And let's also reflect on those features critically, just as we did with looking for intrusive thoughts and compulsive behaviors. So one of the reasoning for the grouping would be that the age of onset is similar for all of those disorders. So if we look at the age of onset for OCD, basically OCD can break out at almost any age in your life, but the most common time frame for developing OCD would be from late teenage years to mid 20s. With men, it's usually a little earlier than with women. And indeed, most of the other obsessive compulsive and related disorders also have their main age of onset, or the most common age of onset is in this range. So you might say, oh, yeah, that's a reason to group them together. However, many depressive, bipolar, anxiety related, somatic, dissociative, sexual, sleep related, personality, substance related, psychotic, or eating disorders also have their age of onset in about that period. So I wouldn't say that age of onset is necessarily something that sets apart OCD and related disorders from others. So I would take that argument with caution. The same goes for comorbidity. And I apologize to any one of you who doesn't like coughing noises. I'm trying to do it as little as possible. Comorbidities means that you have two or more psychological conditions co-occurring at the same time. So the idea is, okay, there's a lot of co-occurrence between and OCD and related disorders. So that's why they should be in one group. They have so much in common. And indeed, if you look at the two groups, there's 14% overlap, which is quite a lot because the prevalence of each one of those disorders separately usually lies around 1 or 2%, right? So if you have OCD, your chance of having another obsessive compulsive and related disorder is high, it's 14%. But then again, if you have OCD, your chance to have, for example, an anxiety disorder, which OCD was grouped with anxiety disorder previously, as I mentioned, um, your chance will be 32%, right? So again, this is kind of like a reason that I'm not sure if this is really a reason to group those disorders together. And then finally, we have this idea that there are neuroimaging and neurological common underpinnings to all of those disorders, OCD and the other ones in the group. To go into detail with that now would be far too much. Also, with neuroimaging studies, it's just really difficult to use this as a reasoning because for most of the disorders that I previously talked about, we have very little evidence. We have still very preliminary and limited research to prove what really happens in the brain if you have one of those conditions. Specifically, if I mentioned, olfactory reference disorder is something that we are only classifying. We've only been classifying for 3 years at this point. There is a lot of evidence. There is a lot of neuroimaging studies about OCD because this disorder gets a lot of attention when compared, for example, to BFRBs. But since we don't have enough imaging studies on those other disorders, it's really difficult to draw valid assumptions here. We do have, some very promising, interesting directions. For example, we have a circuit in the brain that's called the corticostriato-thalamocortical circuit. I talked about this in previous webinars in depth. I'm going to just call it CSTC circuit, which is kind of a pathway from the cortex to the striatum to the thalamus and then back that is involved in action in activation versus inhibition in the decision whether to act on an impulse or a trigger or to stop and ignore it. And a lot of disorders that involve impulsive or compulsive behavior, such as OCD, BFRBs, or ADHD, share some abnormalities in this circuit. So you could say that there is some preliminary evidence that there are similarities in the brain function between within this group of obsessive and compulsive and related disorders. But I wouldn't say that this evidence is stable enough to really base the grouping on. Now, before I'm going to talk about how to treat those different diagnoses, since we talked mainly about similarities between all of those, I do want to help you make some important distinctions between, because as we saw before, there is a lot of co-occurrence. So if I just look at, the people who are joining this webinar here specifically, and if I assume that most of you join because you have OCD, then we can know that 14% of you might also have one of those other disorders. So it's very important to be able to differentiate between them. So here I have a few examples for you where we're going to try to understand together what is it really. So here's a case example where I want you to think whether you think this is OCD or body dysmorphic disorder based on the information that you have at this point. Marcus reports being overwhelmed by obsessive thoughts about his eyebrows not being even. It gives him a deep irrational sense that something is off. He experiences sudden intrusive urges to touch his eyebrows until both sides feel the same, or stare at them in the mirror until he feels an internal sense of balance. He spends hours each day mentally checking for symmetry or repeating internal counting rituals, such as blinking 4 times on the left eye and then on the right. He avoids photographs because they trigger compulsions if one side of his face is more visible than the other. It's exhausting. I know my face is fine, but if I don't do these things, I feel unbearable anxiety, like something bad will happen. So here you do have the aspect of body symmetry and kind of something looking off in the face, but still we would not call this body dysmorphic disorder. We would call this OCD, because Marcus basically denies any belief that he is ugly, disfigured, or deformed. He also describes the thought as ego dystonic. He doesn't know why he cares so much about the features in his face being even. He is aware of the fact that his rituals are irrational, but he says, like, but if I don't do them, it just feels so bad. He has no desire for cosmetic procedures, grooming, or makeup. No shame or embarrassment about his actual appearance. So, although we're talking about concerns relating to appearance here, we would not call this body dysmorphic disorder. This would be OCD, specifically just right or symmetry OCD. In the next example, I want you to think or reflect whether you think this is hoarding OCD versus hoarding disorder. Yes, there is such a thing as hoarding OCD, and it's different from hoarding disorder. And it's important to know the difference. Carol was referred by social services after her landlord reported a severe accumulation of belongings that had begun to block exits, attract rodents, and present a fire hazard. Carol lives alone and has filled her one-bedroom apartment with old newspapers, plastic bags, junk mail, broken appliances, and clothing she hasn't worn in over a decade. She insists on keeping nearly everything, saying, I might need this one day. There's so useful information in those newspapers. She feels very anxious or distressed at the idea of discarding items, even ones most people would consider trash. When her family tries to help, she gets defensive, saying, it's not that bad. I just like having my things around me. And so here, this is another example of hoarding disorder. It's not hoarding OCD for the following reasons. With OCD, you usually, if it's not just right OCD, have intrusive, unwanted thoughts that cause anxiety. And this anxiety then causes the compulsive behavior. So when you have hoarding OCD, you might have intrusive thoughts such as, if I throw this away, something bad will happen. Or what if I throw this away and someone needs it to stay safe, and then it's my fault that they didn't stay safe. Um, so it's usually you have negative thoughts that make you fear the outcome of throwing things away. For Carol, her thoughts of like, I need this, I might still use this, are ego syntonic. They are, and she believes those thoughts. She doesn't necessarily think that those thoughts are exaggerated, which again is a sign that it's probably not OCD. And her saving behavior is not a ritual to prevent a fear outcome or reduce anxiety. It's driven by sentimentality, the perceived usefulness of the items, and emotional attachment. So, although the outcome of hoarding OCD and hoarding disorder might look very similar, the underlying reasons are very different, and that makes a difference for treatment. And that's why it's important to understand the difference. Finally, is it hypochondriasis or OCD? Nora has been consumed with the fear that she has a serious undiagnosed illness. Over the past 2 years, she has visited more than a dozen doctors for concerns ranging from stomach cancer to multiple sclerosis to ALS, despite repeated tests showing no abnormalities. She's hyper aware of physical sensations, which she interprets as signs of serious illness. She spends hours online researching symptoms, comparing them to her own, and seeks reassurance from doctors, family members, and forums. When others try to point out that she's exaggerating, she replies, this isn't anxiety. I can feel that something is off. The doctors are missing something. So, to be honest, when I thought about case examples for this is a case example for hypochondriasis, not OCD, I was like, but why is it not OCD? Like, you have the what if thoughts. Like, what if I have an illness? What if this is a sign of cancer? You have exaggerated fears, and you have highly ritualistic uh, behaviors. But there are some key differences between OCD and hypochondriasis. Um, for me, one key feature is that OCD is usually a fear directed to the future. If I don't do this now, something bad will happen in the future. With hypochondriasis, it's more like, okay, something bad is already here. I'm already sick. I'm just not sure if it's like, I just have to get final evidence that this is true. Like I'm doubting that I have an illness that's already with me that happened in the past. Now I just have to gain clarity on whether I have it or not. So the fear is for OCD is directed towards the future usually, and for hypochondriasis, it's more like direct towards the present or even the past. Hypochondriasis also is usually revolves around realistic fears. They're just exaggerated. I mean, we all sometimes get scared that we might have an illness or what some of our physical sensations might mean. It's just very intense and exaggerated for people with hypochondriasis, whereas many people with OCD might feel that their thoughts are bizarre or irrational, not a realistic fear that became too much. And then finally, there's just specific rituals that you see more specifically in hypochondriasis, such as doctor shopping, body checking, and internet searching, researching diseases. Um, Finally, I just want to talk quickly about how you treat those different disorders. So, as I mentioned before, in terms of the intrusive thoughts and the compulsive behaviors, OCD, body dysmorphic disorder, hypochondriasis, and olfactory reference disorder share a lot of similarities. So, it's not surprising that also in terms of treatment, they are very similar. There's specific strategies such as exposure with response prevention, meaning I expose myself to a triggering thought or a triggering situation that makes me want to perform a compulsive behavior, but then I don't do it to see that nothing bad will happen. And whether that means that I am not going to check whether the stove is still on, or whether I'm not going to check my face in the mirror to see if it's deformed, or whether I'm not going to smell my armpit to see if I'm super smelly, or I'm not going to go to the doctor for the fifth time to check whether my blood measures are off. It doesn't matter. It just means live with the fear, don't do anything about it. Um, then there's also a lot of cognitive strategies that would be useful for all four of those disorders. And finally, ignore habit reversal training for now. SSRIs, which means antidepressants, um, um, that's the abbreviation for selective serotonin reuptake inhibitors, which means that they increase the serotonin levels in your brain. Those antidepressants are also very effective for all four disorders. And interestingly, for most of them, you also need an increased dosage, just as you need with OCD. So if you treat depression with with SSRIs, you usually need a lower dosage of SSRIs than what you would use for OCD. That's why if you ever look for medical treatment for your OCD, be sure you are talking to a psychiatrist that know how to treat OCD, because it's not like treating depression or anxiety. You need a higher dosage and you need someone who is experienced with it. And so this kind of like needing a higher dosage is true almost for all of those other disorders as well, which is very interesting. However, when you look at hoarding disorder and body focused repetitive behavior, it's a little bit different. Excuse. Okay. So ERP, exposure with response prevention, is not that effective for hoarding disorder and not effective for BFRBs. Cognitive strategies, you can use them for hoarding disorder, but you might use different strategies than for the others. And with body focused repetitive behaviors, cognitive strategies play a smaller role in the treatment. Then you actually have a really, really good way to treat body focused repetitive behaviors, which is called habit reversal training, that would not be effective with any of the other disorders. And there's not sufficient evidence that SSRIs are very effective for either hoarding disorder or BFRBs. With BFRBs, you have some preliminary evidence that it sometimes can help, but there's definitely not enough to express a clear recommendation. So you see, it's like hoarding disorder, there's still a little bit more similarity, and then body-focused repetitive behaviors kind of seem like someone just threw them into this condition. And that might very well be due to the fact that it's very hard to categorize BFRBs in general. They're just very different. There's a lot of misconception around this topic. And I feel like they always seem like a little bit out of place, no matter where you group them. Yeah. So that's all the information. It's a lot of information, I think, anyways. For now, I'm going to conclude. OCD can be seen as related to anxiety disorders as well as disorders that involve compulsive behavior and intrusive thoughts. Right now, they're grouped with behaviors that are have more focus on this compulsive aspect, similar to BFRBs, BDD, hypochondriasis, olfactory reference disorder, and hoarding disorder. All of those disorders share the compulsive behavior. They can co-occur and might share behaviors and brain functioning. However, it's important to differentiate between the different conditions. Specifically, you should be able to tell apart hoarding disorder and BFRBs from the others because those require a very different treatment. Finally, before we jump into the Q&A section, I just want to remind you that we have a lot of free resources in addition to those webinars that we're holding. You can find us on all the social media channels and on our website, Stop OCD, where we also have a lot of informative articles and posts about the topic. If you have more questions, you can always contact our customer support. And if you are interested in signing up for Stop OCD, then we have the promo code for you now. It's called ProWeb100. All right. Thank you for everyone who listened to me talking about theoretical reasoning of grouping psychological diagnoses for 50 minutes while coughing. Now I'm going to get to the Q&A section. I see there's already some questions. Let's see. If you have questions, then you're still invited to write them down right now. Okay, first question. Does the BDD apply if you have a visible skin condition like acne, eczema, and you're self-conscious about the skin condition? Okay, so acne and eczema basically can be a trigger for BDD or also for skin picking disorder. Actually, skin picking can even be a symptom of body dysmorphic disorder. So those two are also co-occur very often. And you can have the diagnosis of body dysmorphic disorder if you have a visible skin condition, if your perception and preoccupation with the skin condition is exaggerated, right? If you have the skin condition, obviously that's something you want to treat, that's something that you're going to pay attention to. But if you feel it disfigures you, if you feel like you look ugly or deformed, or if you feel like this is ruining your life, if you feel like you can't think about anything else, if you feel like you have to constantly check how it's going, if it's more, if it's less, every mirror you have to look into it, you have to compare yourself with other people, if you feel like it's taking up more and more of your life and causing a lot of distress or stopping you, reducing your level of functioning, then we would say it's a disorder. the way you cope with this condition. So it does. So in short, body dysmorphic disorder does not mean that you're imagining the perceived flaw. It just means that your level of preoccupation with it and the level of and how much it affects your life um, is something that causes you trouble, and that is too much. Yeah. Um, would you diagnose someone with olfactory reference disorder if the client makes it known that she thinks she stinks and she also only showers about 3 times a week? Wait, let me read that again. No, so only based on those two facts, my client thinks she's smelly and she only showers about 3 times a week. I would not diagnose olfactory reference disorder. Again, I do not consider myself an expert on this disorder, but just by reading the clinical description of the diagnosis, I mean, I would have to find some compulsive repetitive behavior, such as either excessively showering or using deodorant or checking for body odor or avoidance behavior, not wanting to be in close quarters with other people, too close to other people, as well as the exaggeration, right? If someone thinks they're smelly when they're actually smelly, then it's not olfactory reference disorder. So I would look for a lot of different symptoms, as well as, which is always the case with psychological disorders, is I have to see some kind of impairment, right? I either have to see the client spending a lot of time on their preoccupations or um, um, uh, experiencing a lot of distress or experiencing a certain level of impairment. I mean, if whatever you're quote unquote suffering from doesn't impact your life negatively in any way or the life of other people, then why even call it a disorder or treat it? Hmm. Okay. What about perfectionism, OCD, and treatment for it? Um, that's a very short question. Um, Perfectionism, OCD is not a category that I'm familiar with in and of itself. Sorry. Um, but I know there's more and more subcategories and categorizations that people use just to have a better description or feel more seen within this subgroup with their own personal symptoms. Not every perfectionism needs to be OCD, and not everyone with OCD is a perfectionist. But if you're asking specifically for treatment in terms of OCD, it really doesn't matter which kind of OCD you have. My answer will always be exposure with response prevention and cognitive restructuring. If the symptoms are moderate to severe, I would add medication. This will be the same answer for all subtypes of OCD, even for just right OCD, where maybe the cognitive restructuring is a little less important. But it really doesn't matter what kind of OCD you have in terms of the treatment. Obviously, it matters in terms of how you see yourself, how you restructure your thoughts, where in your life it affects you. But the treatment will always be some kind of adaptation of ERP in combination with cognitive restructuring and possibly medication. Is there a chance olfactory reference disorder might be similar to somatic delusion? Um, First of all, that's interesting that there's so many questions about olfactory reference disorder. Um, wow, that's it. Like, I'm not sure I can give a valid answer to this right now. Somatic delusion also, I don't think is a clinical category, at least not that I know. Like, I wouldn't know if that is categorized in the ICD or the DSM with specific criteria of what it is. Is there a somatic feature in there, maybe? I mean, I could see a somatic feature in hypochondriasis in terms of like I pay a lot of extra attention to physical sensations, and I kind of like may even intensify them by paying attention to it. Might be the same for olfactory reference disorder in terms of I'm constantly focused on my sense of smell, and thereby I might exaggerate um, those sensations. Yeah, but like as I think that somatic delusion really is not a clearly defined category, this is a hard one to answer. If this question is really on your mind and you want it answered, then please feel free to send it to our customer support and they will forward it to me and I will look into it a little bit further so my answer can be a little bit more based on knowledge and not my intuition right now in the moment. Well, those are very interesting questions. Thank you so much. I think that's it for today. Thank you all of you for joining. We're finishing right on time. And I hope wherever you are in the world that you have a nice rest of your day. And I really hope I'm going to see you again for our next webinar.